Dr. Alan Sifany back at the University of Idaho.
Jim May, University of Idaho.
And today we're going to talk about an a priori study or your clinical practice studies where you have a topic that you want to explore, and it's really kind of important that we figure out, well, where do we start this? All too often, working with master's and doctoral students through the years, what we find is that people get an interest in an area and they're so keen about the area that they kind of neglect where we've been before and what we know. And so sometimes when we do that, it's fine, right? But what happens a lot of times is when we start in the middle and then we get results, we don't know what to say about those results and we don't know how they fit. So we like to have a little bit of a process with, okay, we have a topic that we want to explore. And let's say we have a novel treatment or novel paradigm. We've studied primal reflex release technique, and we're some of the first people to study that in a scientific way. And one of the first questions you have to ask is, well, has anybody researched this? And if they have, then where are we on that? Right? What do we know? What do we think we know? How did they measure it? All of those factors are really useful. And then there is, well, how good am I at that topic, right? If you're just learning primal reflex release technique, the question is, should you be researching it? The answer for me is yes, right? Because you want to know how good you are. But at that point, you wouldn't be saying, this is whether primal reflex release technique, or whatever the topic is, works. You're saying, well, I'm doing this technique. This is how I'm doing it. This is my level of experience. I'm probably on the novice or rookie end of this. This is what I found. And you're keeping everything within that context. And it doesn't make it not valuable. It just puts it in proper context. And really what we're trying to do in all of the research is lay it out in a manner so that somebody reading it can properly interpret where we are.
So you're recommending that we have the individuals start to develop their confidence and competence with a specific technique as they investigate it.
Yeah, I think that's definitely a way to do that. You can also be the expert in something first and then study it. But if you're not, just make sure that people know where you are and how, the level of training and the level of your confidence in that. And what we've seen in a lot of research is that the clinician's confidence a lot of times is more important than their skills. But not always, right? And it'd be nice to know, what was the factor here? Was it the person's confidence, or was the skill so robust that it didn't matter that somebody just learned this 2 days ago, which we've had before? And so I think just making sure that people know where you're coming from, where you're starting, it's helpful. And then obviously we work toward competence. But in most of the research studies you read about a technique, what you don't know, and what I've seen behind the scenes in 20 plus years of doing this, is that most of those studies are done by novices, guided by somebody that doesn't know the technique or the thing that they're studying. And I would say that that's the majority of the research we see. Every now and then, we have an expert like an AT. You have Kevin Guskowitz studying concussions. He knows about concussions, right? But in many programs, like a master's program or a doctoral program, you might have 10 different students or 20 different students, and they're researching 10 or 15 or 20 different things. And so you can't possibly be the expert in all those areas. It doesn't make it irrelevant. It makes it, hey, let's look at the context here. This is especially true when you don't find a positive result or a significant result. Like, just understanding the inputs gives context, and it gives people a way to understand, well, how do I take this information and what should I do with that? And most of the time, to maybe be a little cynical, the reason that it's left out is because people feel like they're not going to get published if that's put in there. But I would say I would err on the side of being honest and helping the research move forward and helping practice move forward versus trying to make sure that you only present significant results, or that you only you don't highlight some of the potential flaws in it. And that's a personal perspective. And in this process, we really just want to say, okay, well, what are our inputs? Where do we start? So let's say that we have a starting point of a topic that we know a little something about. We have some competence in it. Where do we go?
Yeah, I think that we can use your PRRT, or primal reflex release technique example, right? So clinically indicated to down-regulate a patient that we would label as or classify as upregulated.
Yeah, or re-regulate.
Yeah.
Somebody who's down-regulated might come up, right? But most likely they're coming down.
Yeah, and they notice that's a trend in their clinical practice. So they have the option to start off like you suggested, get the scope of the research that's been on that type of patient with PRRT, and consider what the landscape is, and then how they want to start to, one, integrate that into their clinical practice and also study it. Okay, so that would be a nice starting point.
Kind of the similar level of starting point of a retrospective study in your practice, where you see a phenomenon and then you go back and you dig it out. And then maybe the next one you set up is a case study. I only get 2 of these a year, so I'm going to do 2 case studies on this. But this time I'm going to use my a priori approach or advanced approach and see if I can tighten down my parameters so that I can say more. Eventually you might get multiple people, or over the course of 10 years you might get enough people to start to make some inferences that go bigger than your little individual population. At times there are cases where you have expertise, you have the ability to, you have a patient population that is just ready for you to work with. It's the patient for example, you're working with lower extremity sports, you're doing a lower extremity technique or evaluation process or something, and it all matches up, and you can move through those layers of quality research really easily. At some point we'll talk about our cohort model, where multiple people are measuring the same kind of thing, and some advantages and disadvantages of that. So let's say that they have a topic that there's a bunch of research out there. Where do they go after that?
So like a lateral ankle sprain?
Sure, yeah.
Tight hamstrings, that's a highly researched, highly treated, high occurrence rates, those kind of things.
Yeah.
So lateral ankle sprain, which is a good example, and most sports medicine practitioners experience treating many lateral ankle sprains over a year. So, and then we could consider that population. We know what the gold standards are, the best recommendations.
Or the iron pyrite standards.
Yeah. We need that for a starting point.
Yeah.
We understand what the best recommendations are, meaning that we understand the literature, we understand what the recommendations are, and we know how to integrate those into clinical practice.
And if we pause that for a second, that's a great pitch for understanding your local practice. You get a lot of lateral ankle sprains, but you still don't have anything to compare it to, because if you look at our recommendations, NATA, it's just a bunch of things that are listed that there isn't a ton of evidence for, or the evidence isn't explicit, right? And so you'd want to know what your standard of care is without that. So if you had 10 years before you had a particular technique, And then all of a sudden, you implemented this technique. Now we can look at two different parts of our practice.
Yeah.
But the only way we can do that is if we have data to start with, if we're collecting data in our clinical practice and things of that nature.
So we have an understanding of that patient population of lateral ankle sprain. And then I think in this case, Mulligan concept is a really nice conduit to studying your clinical practice. Mulligan concept would be clinically indicated for a grade 1 or grade 2 lateral ankle sprain that you've classified and diagnosed, and you can integrate that from acute levels to subacute to chronic.
And so when you say classified properly, that's one of the big bugaboos in this area, is if we don't pin down what we're actually talking about, like, you know, did we have inclusion criteria such as they had to have demonstration of laxity, or they had to have complaints of instability but no laxity, or they could have either. Having that established beforehand is really good. Understanding what ligaments you think might be involved, understanding the range of motion restrictions, understanding the strength restrictions, all of the things that we would normally check, but making sure that we have some way of measuring that and speaking about that is really good. And then if we can classify like cases together, we're way better. I'd rather see 2 cases that are really similar compared than 10 cases that are just kind of haphazardly thrown together that all involve the ankle. When you talk about the Mulligan concept, and the question is, are you going to be using the Mulligan concept and anything else?
Yeah, good.
Our recommendation is if you have anything else added to that, you dilute everything. And our experience has been, even if you add like stretching, for example, which we generally don't do, but if you added that, because people are familiar with that, all of a sudden they say, well, it's because you stretched them, or because you gave them an ice pack. And so if you don't if you don't know for sure that these things won't work by themselves, especially when you're dealing with a complete treatment paradigm or a relatively complete treatment like Mulligan, that can actually restore on its own without strengthening, without stretching, without our towel crunches and all the things that we were kind of trained to do. If you have a treatment that says, a lot of times you don't need that to get full motion, full function, reduce edema or effusion, depending on the area you're talking about, then don't add it in. If you need to add it in, but know it's going to be harder to say anything about it. And at that point, let's say we just use Mulligan. Now we've got it really clean and we've classified them properly. Are we going to do one technique, or are we going to do the techniques that are indicated? Are we going to do the same technique for everybody, which means that some people it'll probably be indicated for, some people it won't.
Yeah.
You can do a battery of techniques if you use that model, where you don't know. Some people need it, some people don't. It's not going to hurt them to do it. It's just not going to help them if they don't need it. But at that point, you start to say, well, now we're using the known and common Mulligan concepts. We're considering all of those that might be indicated for that ankle injury. Or you could say we're going to do one technique, and we're really not and we're not doing anything else with it. So one of the Mulligan ankle techniques, nothing else with it. And we're going to see what effect that has on our population over the course of 3 visits or so. I say 3 visits because we could do it over the course of 12 visits, but if it's not working after 3, or if they need something else, and you're dealing with real life patients, you gotta be able to compromise it at some level. But at that level, you're not really studying the Mulligan concept. You're studying one angle of the Mulligan concept that may or may not be the only thing they need, right? That's fine. Just say it. Make sure everybody knows the angle you're taking so that they can read your research paper and say, yeah, that makes sense. And I'm going to take that with the grains of salt required for the level of evidence that was provided.
Yeah, so, I mean, on that topic, right? So you had that traditional approach to treating lateral ankle sprains, right? And And what you're going to investigate in this example, when we talk about the Mulligan concept, is that you're going to challenge that theory a little bit, that based on the use of and the clinical indication of the Mulligan concept, that it may not be solely a ligamentous or a tissue pathology injury. Okay? So, and that's how you're going to look at setting up your next step. So we're going to say,
so you're guessing ahead of time that, you know what, if I'm right, or if my practice is accurate, that these things that should actually hurt shouldn't feel good for the patient and definitely aren't going to help anything, will actually be the thing that helps somebody. So that's what I'm studying. And so you're setting it up in a way that if it comes out the way that you think it's going to come out, you can actually say what you want to say.
And in this case, we would expect, if it was a grade 1 lateral ankle sprain, we would expect the Mulligan concept to have immediate changes. And we would be able to study those from a pre to a post care.
All the way up to a grade 2, maybe even a 2+. And sometimes as it gets closer to plus, grade ankle sprain, not ligaments involved. I hate that terminology, right? 1 ligament, 2 ligament, 3 ligaments, because you can have any combination of those.
Yeah.
So we say in our inclusion, we're going to do grade 1 to early grade 2 lateral ankle sprains, primarily involving the ATF and CF. And if it's anything other than that, we're tossing them. And then we could start there, because most people have a population that they could study that. That's the bulk of the, but you wouldn't want to get people that have a syndesmotic sprain mixed in, or a medial ankle sprain, or the posterior, or, you know, extensive tendon involvement, something like that. So those are all good points. And as you study that area and you're trying to figure out, well, am I having an impact? You know, another thing that you look at with that is, if you're doing range of motion testing, how big of a factor in your research study is that? And the reason I would say that is, in the lab, I'd say measure everything and know your parameters, right? Know if I'm measuring range of motion, how accurate am I, right? Know your validity, know your reliability. All of that is super important. However, when you're in clinical practice and you're trying to get things done as an athletic trainer, in the clinic, you will not be measuring every range of motion 3 different times, maybe getting an external person to validate that. It's just not how it works most of the time. So it might be worth saying, okay, well, let's just take 5 people and see if I eyeball these, how close I get. What is my tolerance within that? And then I'm going to use categories of, they were somewhere between 15 and 20 degrees short of their range of motion. When they're at the end, they're equal to the opposite side, right? So we can knock out some of our time, because if we measure everything particularly in our clinical practice, we'll probably get fired. Or our patients will stop coming in, right? So there's a balance.
They're challenged to use and integrate the most valuable outcome measures.
Yeah, and if I had to say range of motion, or I had to say strength for participation, I would say strength.
Yeah.
And if I had to say strength or agility, I would say, well, maybe we need both. Yeah. Pain's an easy measure to use. We can always have that. But those things that can be time consuming, that the reason I say that isn't because I don't value range of motion. It's because if our other aspects are right, we can always do range of motion first day, and then a mid-time and an end, right? Not every day, right? You can cut it that way as well.
Or use a weight-bearing dorsiflexion range of motion on regular intervals, and then use goniometric measurements on those bigger intervals.
Yeah, and do you have proxy measures that are cheaper and quicker? And when I say cheaper, usually it's a time thing rather than a cost, although a cost could be a factor as well. But if you're going to start doing research in your clinical practice, the way to do it is make it so that it fits into your clinical practice, and that you don't have to change everything to do that. What we know from behavior change is, if you have to change everything, or most things, or even a lot of things, it's not going to last. It's not going to be sustainable.
Yep. So
that's probably a good place to leave this one. And you know, there's always more that we can do on any of these topics. That's why we have a doctoral program, right?
Yeah, there's lots of points of consideration in that.
Yeah.
that discussion.
So if you have comments or questions, then feel free to leave those. And if you like this, share it. You can click like, you can subscribe, all of those things. You can sign up for notifications because I know this. To me, this is enthralling. I don't know about to you, but if you're in my category, then maybe you want to get the notifications when we put out a new one. So thanks for listening. Hopefully it's helpful, and we'd like to hear from you.